Good evening, everyone. Let's all crack NEET PG exams with Unacademy, where we have top educators, quality content, and you will guaranteed have a great learning experience. So, guys, let's crack NEET PG. I'm Dr. Sasha Menon. A little about me. I've done my MBBS in anesthesia from Father Muller Medical College, Mangalore. I have two publications and one paper presentation in the field of anesthesiology, and I have been working and teaching in Bangalore for the past 2.5 years. My topic for today will be local anesthetics. I'll be dividing it into two parts. I'll be covering the first part today and the second part involving the metabolism and the adverse effects and the various preparations of local anesthetics tomorrow. My class tomorrow, the second part on this will be at 5 p.m. So guys, we are here to help you crack NEET PG with India's largest learning platform, Unacademy, where you can get plus subscriptions and access unlimited live and recorded courses from India's best educators. So guys, hurry, get your subscription, don't waste time. What will you get out of Unacademy now? So we have our daily live classes where you can chat with your educator, engage in discussions, ask your doubts and answer polls all while the class is going on. So what happens with your coaching classes is, firstly, the energy and time that you use to travel is saved with these online classes. Those classes are not, you cannot fall back on those classes. Once class is done, it is over. These are recorded as well as live classes. You can always fall back and watch the recorded classes. In your coaching classes, there are a lot of people sitting. It is difficult for the educator to clear everyone's doubts. It is difficult for you. It might be difficult for you to get the educator's attention. It might be difficult to get a proper place in your class where you can see everything, you can hear the educator, you can ask your doubts to the educator. This is all avoided with Unacademy, as you can chat one-on-one with your educator during the class. You can engage in a discussion during the class, and all this while you're the YouTube classes. We also have a special which help evaluate your preparation. There are regular mock tests and quizzes, and these help us get a detailed analysis on your performance. Also, there is unlimited access. One subscription can get you access to all the live and recorded courses to watch from the comfort of any of your devices. So we prepare quizzes for you all based on our classes, what we have taken. So it's like a revision for you all, because you all are going through it. We are going through it with you. We are taking you through it, and hence it helps you get analysis on your performance. You are analyzing your performance, right? You don't have to wait for the test results. It is you who is analyzing your performance. Unlimited access. So it is one subscription and you get access to all the live recorded courses, the tests, the quizzes. You have access to everything with just one subscription, and most of all from the comfort of your place, wherever you are, be it home, hostel, whether you're traveling, and from the comfort of your device. So you can use your phone, you can use your laptop, whatever it is. So whether you're traveling, whether you're at home, wherever you are, you can access these classes. So these are some of our top educators. Dr. Nikita Nanwani, she's a NEET PG mentor for radiology as well as mnemonics and concept focusing. Dr. Mohammad Azam, Dr. Devesh Mishra, Dr. Preeti Sharma. These are some of our batch courses offered. As you can see, there are 19 subjects that you need to cover in NEET PG, and as you can see, there are various courses under each subject. So guys, don't waste time. Subscribe. You need to prepare 19 subjects. We're here to help you prepare 19 subjects. So hurry guys, don't waste time. These are some of our ongoing courses in our platform. That is a practice, like you can see, practice course on GI surgery, neurophysiology, cardiovascular thoracic surgery, a course on larynx, respiratory system pathology. These are some of the popular courses. Now coming to the subscription, okay, very important. I recommend the 12 and the 24-month subscriptions. I'll tell you why, okay. So 1, 3, 6 months, okay, fine. You have 19 subjects. These subjects are not small subjects. This is medicine. These are not tiny. This is not like your these are like, you are covering your entire MBBS. You have to cover for this one exam, your 4.5 years of MBBS. These, as you know, in that 1 year each only, it was so difficult, right? These are not small subjects. These are vast subjects. We are here to help you prepare for these subjects. 1 and 6 months is really not enough to cram so much and prepare for the NEET PG. So take your time. Take 12 months. It helps you prepare better. You will be more prepared because it will be more structured for you. You will yourself prepare in a structured manner. So I recommend go for the 12 and the 24-month course. Also, the 12-month course is more economical. So it's a one-time subscription. You, after 6 months or 3 months, the subscription is over. You cannot fall back. You cannot look at the recorded classes. You cannot undergo the quizzes. You cannot ask. So your subscription is up. You have a year. So it's just one-time subscription and you can clear your doubts and whatever. Quizzes, fall back on the recorded classes, it's all there. So use my code, as you can see at the bottom of the screen, SASHA. Use my code, you get a 10% discount, get your subscription 12 and 24 months. That is highly recommended. 24-month, like I said, it's more economical, and also those who want more time, it's not necessary that everyone has to clear in the first 1 year, and there's nothing wrong with that too. Take your time, prepare well, use the resources that we are offering you. 2 years, again, use my code, as you can see at the bottom of the screen, SASHA. Avail your 10% discount. Hurry up, subscribe, let us help you. Welcome to Unacademy. So these are, today's topic will be local anesthetics. Okay. Now cocaine, it's an ester. So the local anesthetics are basically ester and amide anesthetics. They're divided into two categories. Local anesthetics are not used because of the allergic property. They have a lower potency, duration of action is unpredictable water solubility, basically because of their side effects. So they are known to cause allergic reactions. So we use basically amide local anesthetic. So cocaine, your oldest one, it's an ester of benzoic acid, derived from the leaves of Erythroxyl coca, which of course grows in the leaves of Erythroxyl coca. It is the ester of benzoic acid, grows in the Andes mountains, and it has cerebral stimulating properties. So what are the uses of cocaine? So it was used for localized vasoconstriction, which was required during your ENT and your any plastic, like your nasotracheal procedures, because it needed to cause vasoconstriction and hence decrease the blood flow in these areas so that there was no bleeding, right? So why was its use limited? Basically because its abuse potential. As we all know, cocaine is abuse. So because of its abuse potential, it limits its legitimate use, and it because of the irritant property, okay, that is for consumption, but because of the irritant property that it possesses, it limits topical use as well as injection use, obviously, because it causes irritation and pain. Now, what is the structure of local anesthetics, right? It consists of, it's divided into three parts, as you can see. So it consists of an aromatic ring and a terminal, generally a tertiary amine, right? So the terminal As you can see, the aromatic ring is the lipophilic portion of the, this is the lipophilic portion, that is your lipophilic in the sense it is more lipid soluble. Aromatic ring renders the molecule lipid, uh, renders the molecule, and of course it has an intermediate linkage which can be your either your ester or your amide. So based on this linkage, local anesthetics are classified, right, based on the intermediate linkage, and it has a tertiary amine which is the hydrophilic portion. As you can see, this tertiary amine is protonated, and this gives it can be protonated or cannot be protonated. It is in a stable, it is in a dual phase. This attributes a hydrophilic portion of the local anesthetic. So all local anesthetics contain a desaturated carbon ring, that is your aromatic portion, and a tertiary amine connected by an alkyl chain as shown. Aromatic ring renders the molecule lipid soluble. Aromatic ring renders the molecule lipid soluble. So it renders the lipophilicity. The lipophilic nature of the drug is contributed by the aromatic ring. Okay. The tertiary amine portion acts as a proton acceptor, which makes it behave as weak bases. So this tertiary amine, which is the, as you can see, the hydrophilic, the tertiary amine is the, sorry, the tertiary amine is the hydrophilic part. Okay, renders it hydrophilic. So it is a proton acceptor and makes local anesthetics behave as weak bases. So when it in its quaternary state, that is when it is protonated, when it accepts that hydrogen, the terminal amine is also water soluble. So the hydrophilic nature is only when it is, the tertiary amine is quaternary, otherwise it is tertiary. So when it becomes quaternary, that is when it accepts a proton, the terminal amine, when it accepts a proton, it's protonated, that is when it becomes hydrophilic. So as you can see, like I explained, this is important guys, so you all need to know this, that's why I have stressed on it. These are a little dry topics, but I promise you all I'll come to interesting topics later. But for now, we have to deal with this as these are important, and it's a very scoring subject, anesthesia. In your NEET PG, you get your drugs correct, you get your basics correct about your drugs, what is required. It is very scoring. Scoring only certain basic properties you all need to remember, and it is scoring. That 11 marks is all yours, right? So the lipophilic group, it is an, like I said, aromatic ring, unsaturated benzene ring. Intermediate bond is a hydrocarbon containing chain, either an ester or an amide. This determines the classification. And the hydrophilic group is a tertiary amine and a proton acceptor. So once it accepts the proton, it becomes hydrophilic. Now coming to stereoisomerism, right? So many medications contain chiral molecules which exist as stereoisomers. Chiral molecules are basically molecules which accept groups, right? So chiral molecules contain chiral molecules which exist as stereoisomers. Now stereoisomers can be classified as optical or conformational, right? So a chiral compound is a carbon atom. So a chiral molecule is basically a carbon atom to which four other compounds are attached. Okay. Uh, so uh, So they exist as, like I said, as stereoisomers. There are three types of stereoisomers: optical, geometrical, and conformational. So now coming to optical isomers. So now optical isomers are basically mirror images, right? They are mirror images, but they cannot be superimposed on each other. So they cannot be superimposed on each other. So they are mirror images, cannot be superimposed on each other. And So medications, each enantiomer can affect the body differently. Okay. So now the chiral molecules are asymmetrical and direction of configuration helps categorize a isomer. So how do you characterize these stereoisomers basically? So chiral molecules are asymmetrical and the direction of the configuration helps categorize the isomer. So a molecule which goes to the right is designated as R for rectus, and a molecule which goes to the left is designated as with S for sinister. So S bupivacaine, R bupivacaine, that is basically the direction of configuration. Molecule going to the right is R, molecule going to the left is S. Now isomers rotate with light in different directions. So if the isomer is rotating clockwise, it is dextrorotatory. This is this is the polarity with regard to light. If it is rotating anti-clockwise, it is evorotatory. Now isomers, yeah. Now what is a geometrical isomer? So this is basically the chiral molecules, how they are classified based on their direction of configuration. Right is R and left is S. Based on the polarity, that is the way they rotate light. They are those that rotate anti-clockwise levorotatory and clockwise dextrorotatory. Now what is a geometrical isomer? A geometrical isomer is basically they are stereoisomers that are restricted in movement around the central carbon, the chiral carbon. Okay, so they are restricted in movement chiral around the chiral carbon. They are classified as cis and trans. So you, I'm sure, heard of cis atracurium, cis isomer, trans isomer, right? These are basically geometrical isomers that are restricted in movement around the chiral atom. Conformational is they are not restricted in movement around the chiral carbon atom, and they can conform to a target receptor. So they are not restricted. So they basically change shape and take the configuration of the particular receptor. Yeah. So up to 1/3 of the medications are administered as stereoisomers. So if there are if there are two isomers in equal concentration, it is known as a racemic mixture. So we'll come to this later about racemic mixture, bupivacaine and all. So yeah, bupivacaine is a racemic mixture of R-bupivacaine and S-bupivacaine, right? So even epinephrine is a racemic mixture, so is which is the aerosolized. So aerosolized epinephrine is also a racemic mixture. Okay. So when two isomers of equal concentration, it is known as racemic mixture. Now, what is the main issue with the racemic preparation is that the patient is receiving two different medications. So it is actually the patient is receiving two different medications because each medication has its own property, own potency, own side effects, own onset of action, safety profile, each one. So it is a mixture of two drugs, right? So so when you administer a medication of made up of two different enantiomers, it can result in a different pharmacodynamic and pharmacokinetic effects. So there can be a because of these two enantiomers, there can be a variety of pharmacokinetic and dynamic effects. So one can exhibit greater potency, a better safety profile and reduce side effects as compared to the other, whereas the other one may the side effects may be seen. So as with the bupivacaine, it is a racemic mixture. However, S-bupivacaine, so the bupivacaine is made up of R and S as mentioned here. So now S-bupivacaine has a better safety profile because uh, the dose, it is as potent. First of all, it is as potent as the racemic mixture. So the same amount of drug as the racemic mixture produces the effect, but it is less toxic. So increased doses are required to cause the cardiac and CNS side effects than normal bupivacaine mixture. So this is the as singularly S-bupivacaine is actually better because it it takes larger doses and longer time for cardiac and CNS effects to manifest, and it is as potent as racemic mixture of bupivacaine, right? So it is as potent as that's the same concentration. Now receptors are stereo-specific or stereo-selective. That is stereo-specific, which means that they will only allow one stereoisomer to attach, or it is stereo-selective, meaning they prefer one stereoisomer to the other. So either they can be stereo-specific, that is they are allowing only one isomer to attach, or they can be stereo selective where it chooses which stereoisomer should attach. Now this is the classification, like I told you, the ester and the amides. So your esters are your basically your procaine, chlorprocaine. So your esters are procaine, chlorprocaine, tetracaine, cocaine, benzocaine. Amides are lignocaine or lidocaine, procaine, prilocaine, mepivacaine, itidocaine, bupivacaine, and ropivacaine. This is ropivacaine. In case you all can't see, right? Ropivacaine. Now basics about nerve conduction physiology. So the nerve membrane contains a voltage difference of this. I'm sure you all have already done it in physiology, but I'll just give you all a brief overview. So the neural membrane contains a voltage difference of plus. So at rest, basically the nerve membrane, the voltage difference of plus 60 millivolts to minus 90 millivolts, right? So at rest, basically the inner is negative. I'm sorry, this is not the inner surface of the neural membrane is negative and the outer is positive, right? So at rest, This is outer, and this is inner. Okay, so this is at rest. Okay, this voltage difference, what is written right now, is when depolarization occurs, but at rest the outer is positive and the inner is negative, right? So at rest, neural membrane is impermeable to sodium ions and selectively permeable to potassium. This is important. So at rest, it is selectively permeable to potassium ions, whereas it is impermeable to sodium ions. The potassium to sodium gradient is constant, that is 30:1. So potassium is kept at 30 intracellularly, right? It leaks across the plasma membrane, but it is kept at 30 intracellularly. During a nerve action potential, nerve membrane switches its permeability from potassium to sodium, changing the membrane potential from negative to positive and back again, right? So during an action potential, so I'll show you all. See, this is your nerve. This is an unmyelinated axon. Right? Yeah. So this is your unmyelinated axon. So unmyelinated are basically your C fibers. Okay, first I'll tell you a little about the myelination, right? So it's basically your C fibers, and these are your efferent C fibers and your postganglionic efferent nerve. Okay? So these are basically unmyelinated. Okay, so now in an unmyelinated nerve, it is positive outside and negative inside. When an action potential comes, right, during an action potential, currents are created, and this becomes negative outside and positive inside. So it reverses, and it leads to a current within the membrane. So because of this depolarization, the sodium channels which are located here get depolarized, activating adjacent sodium channels, and this passes down along the nerve. This causing the depolarization passes along the nerve. Local anesthetics bind to these sodium channels and block these sodium channels. Now, what is the mode of transmission in a unmyelinated nerve? So, in an unmyelinated basically in what does an unmyelinated nerve look like? So basically an unmyelinated nerve, a non-myelinated nerve is enclosed in, so 5 to 10 axons. So these are your nerve axons. So 5 to 10 axons are enclosed by a number of Schwann cells. Okay, but it is all enclosed by one layer of the Schwann cell, but there are a number of Schwann cells that are enclosing this. Okay, but so it is all being enclosed together by a number of Schwann cells, but the Schwann cells have a single membrane. Okay, the membrane for the Schwann cells is one, but there are a number of neural sheets are in number of bundles. So these are bundles of around 5 to 10 axons are enclosed with a number of multiple Schwann, but with a single membrane, one layer of the membrane. Okay, now one myelinated fiber, your myelinated fiber, each myelinated axon, so each axon is enclosed, each axon is encased in multiple membranous wrappings of myelin formed by one Schwann cell. So one Schwann cell, I'm sorry, One Schwann cell uh, causes multiple encases, about 100 encasements of myelin around this single each axon. So each axon is enclosed. This is just one axon, one Schwann cell, and this is multiple layers of myelin. Okay, so in unmyelinated, non-myelinated fiber, it just the depolarization just goes down the nerve. However, in a myelinated fiber, so myelinated fiber, myelin basically increases the speed of conduction, okay, and it insulates the axolemma from the surrounding salt medium. So there is surrounding salt medium, sodium, potassium. So it insulates the axolemma and it increases the speed of conduction. So basically the sodium channels are more located. So this is the axolemma, right? This is your axolemma. So your sodium channels are located more here. These are your nodes of Ranvier. Nodes of Ranvier. The node of Ranvier is where your sodium channels are concentrated in a. So in a higher concentration at the sodium channel, the nodes of Ranvier are impulses basically generated here, and they jump from one node of Ranvier to another. So the impulses are go like this. They are not conducted throughout the nerve. The impulses jump from one node of Ranvier to another. Now what is the mechanism of action? So local anesthetics basically block voltage gated sodium channels, and thereby, which are located, I told you, on the unmyelinated and myelinated nerve. I just explained the myelinated, unmyelinated, the sodium channels are located throughout the nerve. So the local anesthetics block voltage gated sodium channels and interrupt initiation and propagation of impulses in the axon. So there are sodium and potassium channels both. So basically sodium is outside more and potassium is inside more, right? Selective. So the in resting phase, the membrane is selectively permeable to potassium and impermeable to sodium. But whenever there is a depolarization, the membrane becomes permeable to sodium. Okay, so a small depolarization will open the sodium membranes, and the potassium membrane also opens because potassium has to move out and sodium has to move in. But what happens with these potassium membranes is they open less slowly than they take time to open. So the sodium channels are quick opening. So the sodium, the current moves through these channels, depolarizes this sodium channel, and this depolarizes the next sodium channel, and in the myelinated fiber at the nodes of Ranvier, and that's how the depolarization progresses until the sodium and enough potassium channels have opened. So as the sodium channels, so the sodium channels exist in resting, activated and inactivated state. Okay, so sodium channels are basically voltage gated channels. They have two gates. I have explained in my previous classes. So sodium channels have two gates, which is a voltage gated gate and a time dependent. So this is time, this is voltage. Okay, so whenever an action potential comes and it in the resting phase, the voltage dependent gate is closed. At rest, this gate is closed, whereas your time dependent is open, right? Okay, now voltage dependent means it depends on voltage. So when a depolarization comes, this gate opens. Your time dependent gate is also open, so the sodium ions will move through this and they will cause depolarization. Now this is a time dependent gate. So as the depolarization is occurring, after a certain time this gate will close, so the sodium channels will stop moving through. That is your inactivated phase. That is, voltage gate is still open because there is some depolarization occurring. So your voltage gate is open, but your time dependent gate is closed, right? So time gate is closed and your voltage gate is open. This is your inactivated sodium channel. And your sodium channel at rest is all, of course, what I initially said, where the voltage gate closes and the time gate opens and there is no movement of ions, right? So as these sodium channels get activated and activate neighboring sodium channels, the sodium channels get into the inactivated state and there are enough of potassium channels which have opened. This balances shifts the balance of current to a net outward moving current, because there is no inward movement because the sodium channels are in the inactivated state, which leads to repolarization. Okay? So your local anesthetics are basically inhibiting these sodium channels, and they are preventing depolarization. Now, the sodium channel consists of large sodium conducting core alpha subunit and varying number of adjacent small beta. Consists of a large alpha central conducting core alpha subunit and number of smaller adjacent beta subunits. The unionized base form, which is lipid soluble. Okay, so like we discussed just now, unionized, that is, it is not protonated. Okay, no, not protonated. So the tertiary amine, basically it is more basic. So it is the unionized tertiary amine is the more active form. There is better lipid, it is more lipid soluble, hence it penetrates membranes better, hence it is the onset of action will be faster. So the unionized base form, which is lipid soluble, diffuses through the cell membrane, whereas the charged form is much more active in blocking the sodium channel. So the quaternary amines, basically they are more water soluble, right? And they are more active in blocking the sodium channel. So their onset of action is slower because they take longer to penetrate uh, the the lipid layer of the cell membrane. Now, sodium channels, like I said, exist in activated open and inactivated closed form, and rested closed states during various phases of action potential. I just explained to you all. Local anesthetics, they have a selective binding. Okay, they bind to sodium channels in the inactivated closed state. Okay, so in the inactivated closed state, that is basically in the inactivated state. So before, from the inactivated, when it's going to the closed state, they bind to the inactivated state of the sodium channel. They stabilize the channel by inhibiting the conformational changes that underline the channel activation. So they bind to it, they do not allow repolarization. They cause a conformational change. Inactivated, they do not cause repolarization. The slow rate of depolarization of nerve action potential, it slows the rate of depolarization, and thus threshold potential is not reached. So it slows the rate, no threshold potential, no depolarization. Action potential cannot be propagated and conduction blockade results. So they have selective binding to the inactivated and the active states. Okay, I'm coming to that. So a frequency dependent blockade, that is sodium ions recover from local anesthesia induced block between action potentials. So in between action potentials, the sodium ion channel actually recovers and develops an additional block each time the channel opens. So it recovers. So it binds selectively to open and inactivated channels. Okay. The binding to closed channels is also, it also binds to the closed state of the sodium channel, but it is much slower. So these two, open and the inactivated state of the sodium channel, is what the local anesthetic molecule prefers. So it binds to the, when it binds preferably more to the inactivated. So when it binds to the inactivated, there are still some channels which are in the open state, right? So it, in between action potentials, there is the action potential is propagating down the nerve, right? So in between action potentials, they develop, because these channels, it also binds to the open sodium channel, so additional blocks are developed. each time the channels open. So it gains access to the sodium channels only in the activated open state. So conduction block, nerve characteristics, resting nerve is less sensitive. Okay? So for a block to occur, a resting nerve is less sensitive. So the binding of local anesthetics, why is it in the binding of local anesthetics? Basically, why is it increased? By membrane depolarization. This is for two reasons. So more binding, obviously during activation there are more binding sites. Sodium, the local anesthetic preferably binds to the sodium channels when they are in the open phase as well as the inactivated phase. So during depolarization, more binding sites are available, and drug dissociation from the inactivated sites is slower than from the resting channels. So the drug is still bound in the inactivated state. The time channel is closed, but there is depolarization. So it will not leave the sodium channel. It will take a longer time to leave the sodium channel. However, in the resting phase, there is no depolarization. So the drug dissociates quickly away from the sodium channel. So this is important. What is a state dependent blockade? The local anesthetic ability to bind the sodium channel is state dependent. That is, it depends on whether the sodium channel is in the open, inactivated or resting phase. They bind, sorry, that is not mine. They bind more readily to sodium channels during depolarization, that is when it is open, and they may bind to the resting, but but not as readily to the open or the inactivated state. So I'm going on in emphasizing this because this is a mechanism of action that will be asked here. So it binds more readily during depolarization, that is in the open, and it also binds more during in the inactivated state, but not so much in the resting state. Now coming to structure, activity. So now briefly about summary of the mechanism of the local anesthetic. So solutions of local anesthetics, they are basically deposited near the nerve. Okay, so they get, so initially when they are deposited near the nerve, the local anesthetic, so they get removed by tissue binding, protein binding, circulation, local hydrolysis, and whatever is remaining is free to penetrate the nerve. Okay, it then penetrates the nerve. It penetrates the nerve axon. It penetrates the nerve axon and accumulates within the axoplasm. So it penetrates the nerve axon after undergoing tissue binding, hydrolysis outside, penetrates the nerve axon and accumulates in the axoplasm. Okay, the speed and extent of the process, so it depends on a particular drug's pKa and the lipophilicity of the base and the cation state of the species. I will be coming to that. So just remember, it depends on the drug's pKa, the lipophilicity, this penetration of the, and whether it is in the ionized or unionized state. So the unionized state is more lipid soluble and helps in better penetration of the axonal membrane, because of the cell membrane has the lipid bilayer, so it helps in the unionized form is more lipophilic and helps in better penetration, faster onset of action. Okay, so this penetration also so that's what the onset of action, basically the penetration of the axonal membrane, right? So this pK is basically the equilibrium between the ionized and the unionized form, right? The higher the pK, the more unionized fraction of the drug is present, more permeability, right? So binding of local anesthetics, now once they are inside, they bind to the sodium channels, prevent opening of the sodium channels and produce a conduction blockade. Okay, then after that, how does it dissociate? Okay, the onset and recovery is governed by the slow diffusion. So the onset and recovery of a local anesthetic is basically governed by the, depends on the diffusion, basically depends on the diffusion of anesthetic molecules, diffusion out of the nerve. It does not depend on the binding or to the sodium channels. So a block that may last for many hours can be accomplished with the local anesthetic that rapidly dissociates away uh, from the sodium channel. So the onset and recovery depends on diffusion into and out of the nerve. Now, structure activity relationship. The intrinsic property and duration of action are the intrinsic property and duration of action are dependent on the lipophilic hydrophilic balance and the hydrogen ion concentration. Okay, so basically remember this: the potency, duration, and onset of action depend upon the lipophilicity and the hydrogen ion concentration. Now, the lipophilic hydrophobic balance. A high lipid soluble local anesthetic, that is more unionized form, that is a tertiary amine, have a longer duration of action due to decreased clearance by the localized blood flow and increased protein binding. So the highly lipophilic lipid soluble local anesthetics, they have a longer duration of action because they cannot be cleared by blood flow because the blood pH is acidic, right? These are more basic drugs, so these will not be cleared. pH of blood is acidic, and these are basic unionized because they are highly lipid soluble, unionized basic form, and they have a longer duration of action because of decreased localized blood flow and decreased clearance by the blood flow, and they are more protein bound. High lipid soluble agents are more potent and tend to have a longer duration of action. So they are more potent also because a little the amount of drug required to produce an action is much lesser for the above reasons. Okay, so now a low pKa generally correlates with a rapid onset. So I'll tell you this. So now pKa is basically the pH at which the unionized and the ionized form of the local anesthetic are equal. So basically the tertiary amine before protonation is the unionized form, which is more active. Okay, and the quaternary amine, like I said, after protonation is the ionized cationic form. Okay, so pKa is the pH at which the ionized and the unionized form are of the local anesthetic are at equilibrium. So local anesthetics are weak bases which contain a positive charge on the tertiary amine at physiological pH. So basically they are acidic. They are weak bases, but they contain a positive charge on the tertiary amine at physiological pH. So they are basically acidic at physiological pH. It exists, so they basically exist in equilibrium between the basic charge form, which is lipid soluble, the uncharged form, which is lipid soluble, and the charged form, which is water soluble. So the ionized form is water soluble, right? So a low pKa generally correlates with a rapid onset. So a low pKa generally correlates with a rapid onset because they will be more hydrophilic. That is, more the pKa is closer to the physiological pH, they are more water soluble, right? So quicker onset, so the onset is quick. So lower pKa, okay, as you can see, a lower pK. The exception is 2-chlorprocaine, which has a rapid onset even though it has a high pK. So chlorprocaine, as you can see, has a high pK but it has a rapid onset. Now high lipid solubilities, like here, high lipid solubilities correlate with increased potency and duration. So like you can see, high lipid solubility, bupivacaine, ropivacaine, these have a higher pK. They are not close to the physiological pH. So the onset is late, okay? Delayed onset, whereas your lignocaine is more closer to your physiological pH of 7.4, and hence its onset is, it has a quick onset. Okay, because more water soluble, because it is more towards the cationic form is present, right? Because it's closer to physiological pH. So these two have a late onset of action, bupivacaine and ropivacaine. However, they have a greater lipid solubility and hence their duration of action is long. As you can see, lignocaine has a short duration of action. Okay, whereas these two have a long duration of action because of relative lipid solubility not cleared by the circulation as well as more protein binding. Okay, these contribute to the long duration of action and increase potency. Increased protein binding retards absorption from the site of injection and prolongs action. Now, local anesthetics are weak bases and contain a higher ratio of the ionized medication. Increasing the concentration of the unionized form will speed the onset of action. Okay. In general, local anesthetics with the pKa that approximates physiological pH will have a higher concentration of non-ionized base, resulting in faster onset. So, a pKa with a physiological pH closer to physiological pH. This is important, guys. Like I said previously. Okay. So, a local anesthetic which has a pKa near the physiological pH will have more unionized, that is active form of the drug. Okay. So, here the pKa, oh I'm so sorry, I don't know if I confused you all previously, but this is it. The pK here, it is more closer to the physiological pH of 7.4. So more with lignocaine, so more unionized fraction of the drug, which is the active form of the drug, and hence onset is faster. Okay, so low pK basically closer to physiological pH. Okay, more unionized fraction of the drug, as hence onset of action is faster. Bupivacaine, ropivacaine have a pK more towards the basic side. They have more of the, because they are more protonated, so they have more of the ionized form and hence slower onset of action. Okay, so here is local pKa versus the onset of action. As you can see, lignocaine 7.4, the onset of action is within 2 to 4 minutes, whereas bupivacaine has pKa is around 8.1. It is not near physiological pH. It takes 5 to 8 minutes, whereas your lignocaine 7.8 closer to physiological pH takes 2 to 4 minutes. Now, two notable exceptions are your chlorprocaine, which has a high pKa but still has a rapid onset of action, and benzocaine, it does not exist in an ionized form. It has a different mechanism of action. So, what are your clinical implications of this? The clinical formulations of local anesthetics are prepared as hydrochloride salts. Okay, they are prepared as hydrochloride salts to increase their solubility in water. So they are prepared as, because they are basically not water soluble. So to increase the water solubility, they are prepared as hydrochloride salts, the pH of which is 5 to 6. So more unionized fraction will be present, right? Now these solutions are usually acidic, pH of 5 to 6, and to enhance the formation of water soluble quaternary amine and to prevent so when epinephrine is present in these solutions, local anesthetic with epinephrine, the pH is made even more acidic. This is because it needs to enhance the formation of water soluble, to make it more water soluble, and to prevent oxidation of epinephrine which is present in these solutions. This slows the onset of action. So here the pKa again is becoming acidic. Okay, so again here this will slow the onset of action. This is ideal. It is closer to physiological pH, and this is made a little more acidic. This is still not ideal. Okay, you need it closer to the physiological pH. This is still acidic, but this is done because they are insoluble in water, to increase their solubility, right, with hydrochloride salts. So for to make it water soluble with epinephrine, it is made even more, the pH is made it is made even more lesser of to 4 to 6. This will again slow the onset of action. To enhance clinical onset, to make the onset quicker, instead of hydrochloride salts, carbonated sodium bicarbonate can be used. This makes the pH more basic. So when you add hydrochloride salt, it's making the pH acidic. You're slowing the onset of action. But with carbonated solutions, especially with epinephrine, so 5 to, because you make with epinephrine, if you use hydrochloride salts to make it soluble, you make the pH even lesser, and hence the onset of action is delayed. So carbonated solutions are used for epinephrine, which makes the pH more basic and increases the amount of non-ionized form, hence speeding the onset of action. But too much of sodium bicarbonate can lead to precipitation. Now, what are the factors that affect local anesthetic action? So, coming to the factors that affect local anesthetic action, a pKa. So, lower the pKa, greater the amount of drug in the anionized form, more rapid onset of action. This we know. Okay? pH. Acidification of tissue, as with sodium when you need to put epinephrine, you make it more acidic. It decreases even during inflammation. During inflammation, the tissue is very acidic. Decreases local anesthetic effectiveness, as most of the solution exists in the ionized cationic form. Right? Now, lipid solubility. Higher lipid soluble agents are more potent and tend to have a longer duration of action. As I have already said, higher lipid soluble and more protein binding. Protein binding. Increased protein binding, the duration of action is increased because more amount of drug is present at the site. Vasodilatory activity. Increased vasodilator activity. This is just an overview. Decreased potency and duration of action, because the vasodilatory activity, so it is cleared away by the circulation, so the potency is decreased. You need to give more drug and the duration of action is also reduced. Now, minimum concentration. Larger nerve fibers require higher concentration of local anesthetics to produce conduction blockade, and increased tissue pH results in decreased minimum concentration. So basically, increased tissue pH because more amount of drug is present in the unionized form. So the minimum concentration is lesser for a larger nerve fiber. Now, differential blockade, that is low concentration. In low concentration, the preganglionic beta B fibers are blocked. With increasing concentration, small c and medium A fibers get blocked. Touch, proprioception and motor functions will be present. In anxious patient, any sensation can be misinterpreted as failure. So what are the changes during pregnancy? So during pregnancy with the local anesthetics, so there is increased sensitivity because of progesterone. So there the rapid onset of blockade. Okay, so there is a more rapid onset of block. This is because of the activity, the progesterone causes dilatation of epidural veins, and there is alteration in the protein binding characteristic. That is, there is increased concentration of unactive of unbound drug in the plasma. There is decreased protein binding, dilated epidural veins, hence more rapid onset of action, more rapid delivery. Hence, we have to give the dose of during spinal anesthesia, the dose has to be decreased during pregnancy because of the activity of progesterone dilating veins, hence more rapid onset of action, more amount of drug is delivered, and altered protein binding, there is increased concentration, so more concentration of the drug is delivered and delivered quickly, so there will be a rapid blockade and the block can rise, causing total spinal anesthesia. So coming to the pharmacokinetics, causing respiratory paralysis. So absorption and distribution, it depends on the site of injection, the dosage and volume, and the addition of a vasoconstrictor agent and the pharmacological profile of the agent itself. So coming to the site of injection, the site of injection impacts blood vessels, depends on the blood vessels, the high vascularity. So high vascularity results in greater uptake and higher blood concentration. Okay, so this is depending on the site of injection. So uptake from greatest to lowest: intravenous, tracheal, intercostal, caudal, paracervical, epidural, brachial, sciatic, and subcutaneous. So depending on the site of injection, the drug dosage has to be adjusted, otherwise it can lead to toxicity. So at the intercostal, if 4 mg of bupivacaine is given here, I'm sorry, in the brachial, if you can give 15 mg of bupivacaine, but in your intercostal, this 15 mg can lead to toxicity, respiratory arrest, cardiac arrest, and death. So only maybe around 4 mg can be given here, because of the high vascularity, more concentration is delivered as compared in the brachial. In the brachial plexus, the drug has to penetrate through a lot of tissue, through the thick nerve sheath, so a lot of it gets absorbed, hydrolyzed, so the amount reaching is less, hence a bigger volume has to be given. However, in the intercostal, it is deposited right around the nerve, so a high concentration like 15 mg will cause toxicity, hence the concentration has to be decreased. So the plasma concentration of a local anesthetic is determined by the rate of tissue distribution and the rate of clearance of the drug. So it depends on the tissue and the clearance of the drug. Initial high uptake into the lungs and distribution of the local anesthetic occurs to the highly perfused tissue. So initial high uptake to the lungs and obviously distribution to the highly perfused tissue. Protein binding, as we have discussed previously, parallels lipid solubility and is inversely related to plasma concentration of the drug. So high protein binding, less drug in the plasma. High lipid solubility, less drug in the plasma. Amide local anesthetics are more widely distributed in tissues rather than ester local anesthetics. So epinephrine, it does not affect vascular absorption of bupivacaine in the epidural space. This is important. It does not affect in the epidural space the vascular absorption. However, it reduces vascular absorption when used for a peripheral nerve block. So, but in the epidural space, it does not reduce vascular absorption. Local anesthetics should never be, especially with epinephrine, should never be injected into an end organ like the ear, nose, penis, finger, or toes. It can lead to gangrene. So with epinephrine, because of vasoconstriction, because of vasoconstriction, if injected into an end organ, like because that there is no blood supply, end organs in the sense there is a blood supply only going to them, there is no blood supply coming from them, right? There is no alternative blood supply, just one blood supply going to them. So if you cause vasoconstriction of that area will get necrosed and gangrene. Lung extraction. Lungs can extract lignocaine, bupivacaine, and prilocaine. This limits concentration of drug reaching the cerebral and coronary circulation. For bupivacaine, first pass pulmonary extraction is dose dependent and the process gets saturated rapidly. So guys, that's it for today. This was the class on local anesthetics, just the basic properties of local anesthetic. The mode of action is it binds to the sodium channels in the active and the inactivated phase, very limitedly in the resting phase, and hence it is a selective blockade. It causes a conduction blockade, prevents depolarization, and it depends. So on the potency, the duration of action, and onset depend on the pKa of the drug, the lipid solubility, and protein binding. pKa, which is closer to physiological pH, there is a faster onset of action because the more of the drug is in the unionized state. As pH becomes acidic, more of the drug is in the ionized phase and the local anesthetic will not act. Highly lipid soluble drugs, they are not cleared by the circulation and they are more protein bound. As a result, their duration of action is longer and they are more potent, right? So this was in brief with epinephrine. So they are basically local anesthetics. They are mixed with hydrochloride salts to make them more water soluble, and the pH is around 5 to 6. But with epinephrine, the pH has to be made more acidic, that is around a pH of 4, which decreases the onset of action. To counteract this, epinephrine solutions can be prepared with carbamate, sodium carbonate, and this makes the pH more basic. And anesthetics for today. Tomorrow my class is at 5 p.m. I'll be taking the second part on local anesthetics. So guys, please do subscribe. Like I told you all previously, please do subscribe and use my code SASHA. Do not delay, guys. Hurry up.